Hello and welcome to this UCSF virtual alumni program looking past COVID-19. Will telehealth endure? Thank you for tuning in and being a part of this virtual experience. Let me introduce myself. So my name is Alex Smith. I'm a UCSFer. I'm a graduate of the UC Berkeley UCSF Joint Medical Program. So I was in Berkeley doing a master's work and my preclinical work from 96 to 99. Then I moved over to UCSF and graduated from UCSF Medical School in 2002. I then went to Boston, trained at the Brigham in internal medicine. Then I did a 1-year palliative medicine fellowship and a 2-year research fellowship in general internal medicine at Beth Israel Deaconess Medical Center. And then I returned to San Francisco in 2008 to the Division of Geriatrics, and really enjoy working with a terrific group there. My research, I'm a clinical researcher, and my research is primarily focused on prognosis, understanding and estimating prognosis for older adults, and communicating prognosis to older adults. I'm also the immediate past president of the Alumni Association, and may have interacted with you in that capacity. And I'm delighted to be your moderator for today's program. Before we start, I want to review a few housekeeping items to help with your experience. First, to submit a question during the presentation, please use the Q&A box. Second, please keep your questions brief. And third, given the size of the audience, we had over 200 people register from this, and the number of questions we have already received and anticipate receiving, our speakers, our panelists, who I will introduce to you in a moment, may not be able to answer all questions. So to start, let me share a little bit about my own experience with telemedicine. So I'll start with a caveat. My role is largely as a moderator. My clinical work in telemedicine was brief and fairly limited and is not a major focus of my research. I will not let that hold me back from talking to you about my experience, however, or the lessons that I drew from this. But my primary role, again, is as a moderator, which I have experience with as I co-host a podcast where we have guests on frequently, and I moderate with Eric Wadera. The podcast is called GeriPal, and we talk about all things related to aging, geriatric, serious illness, and end-of-life care. And if you're interested, I encourage you to check that podcast out wherever you listen to podcasts. So let me share with you my clinical experience in telehealth. So this past March and April, while COVID cases were surging around the rest of the country, we did not have a major outbreak in San Francisco. We were fortunate. And we have our political leaders to thank for taking aggressive early public health measures. New York, in contrast, was getting hammered by COVID, with skyrocketing rates of infection, hospitalization, and deaths. And one of my friends from Palliative Care Fellowship, Craig Blinderman, who's now chief of the Palliative Care Service at New York Presbyterian Hospital, Columbia, reached out to me and a few of my colleagues at UCSF about the possibility of volunteering to conduct telemedicine palliative care consults for hospitalized patients with COVID via phone and video. So we put together a team of about 20 clinicians, including Ashwin Kotwal, who's one of our panelists, mostly from UCSF, a few from Stanford and Dartmouth, to do this telemedicine consult work across the country. So let me set the stage about what was happening in New York at the time. The palliative care service at New York Presbyterian was being overwhelmed. Their service is small. They have about 5 physicians, and their pre-COVID census was 20 patients. That ballooned to over 100 at its peak. And they could, before it happened, they could see this, as they described it, as a tsunami coming, right? They knew this was going to happen. They could almost like envision the water going out before it getting slammed. And when the tsunami hit, it hit the palliative care service in 3 waves. And we helped out at each wave with telemedicine consults. The first wave was in the emergency department. The palliative care service at New York Presbyterian was not previously in the emergency department, but now the emergency department called and said, we need someone embedded here at all times. So one of their physicians, Shunichi Nakagawa, embedded himself in the emergency department. And the typical case in the emergency department would be, a 90-ish-year-old woman with advanced dementia, with suspected COVID, admitted from a nursing home in respiratory distress. She would have no advanced care plan or advanced directive, and the emergency department asked the palliative care team to call the patient's family, who could not be present with her in the emergency department due to visitor restrictions, to engage them in a goals of care conversation. That's the sort of consult that was triaged to us via telemedicine, as the patient couldn't speak for herself, and all discussions with the family would be by phone in any case. So we would call the family and talk to them about their loved one and any conversations they'd had previously related to care in the setting of serious illness. The second wave were patients in the ICU. The ICU called the palliative care service at New York Presbyterian and asked them if someone could be embedded there. This was, again, a new feature for them. They had not previously been embedded in the ICU. The palliative care consultant embedded in the ICU would triage patients to us, and the usual consult for a teleconsult was an older patient with COVID who'd been in the ICU for a week or two and was declining. The patients were typically on ventilators, their kidneys had stopped working, they were on continuous dialysis, their blood pressure couldn't be maintained without the support of medications. And the chart would say the family wants everything done. So we would call the families and we would get to know them. We'd ask them about their loved one in the ICU and get to know their loved one as who they were throughout their life before they were in the hospital. And we build a strong relationship with those family members, calling them every day with clinical updates. And then we'd have the hard conversations with them over time. And we'd shift the conversation from, you did try everything. And now, despite trying everything, your loved one is dying. Now we need to talk to you about how to care for her as she's dying. The third wave were people who lingered in the ICU for weeks and weeks, slowly coming off of the ventilator. In those cases, we talked, again, via telemedicine with family members about the uncertain prognosis of patients who face, weeks to months of recovery, rehabilitation, potentially in a long-term acute care facility, with a potential of not returning to their baseline, understanding that there are really high rates of mortality and never making it home. So people often live the rest of their lives in institutional settings once they're discharged to a long-term acute care facility. So those were sort of the three big waves that hit the palliative medicine consult service that we helped out with via telemedicine. And we were honored to have the opportunity to contribute in some way, because in San Francisco, we felt like, we were fortunate. We didn't have the patient volume, but we wanted to contribute. So this was a way we could contribute in some small way. Nothing like what they faced in New York. Those colleagues there, heroic work, working incredible hours at risk to themselves and to their families. Let me share with you 3 reflections on my own, albeit limited experience with telemedicine. So first, I'd never done telemedicine before, and I was scared. I didn't know if I could do this. But once I started doing it, I realized it was fine. We could follow the same palliative care principles that guide us in everyday clinical practice in-person conversations, building relationships with families, learning about the patient as a person, and then having the difficult conversations. So I guess the take-home point number 1 for me is that we can do this, and that, sure, would I prefer telemedicine to in-person medicine? Probably not. I'd rather sit with a family member at the bedside, but we were able to provide excellent care despite the limitations of telemedicine. So the second take-home point for me was that only one of the consults I conducted was in English. The rest were conducted in Spanish using a professional interpreter via language line. And of course, English language fluency is a spectrum, right? Alicia Fernandez, who's at San Francisco General, wrote about this. I took Spanish in college and traveled around Central and South America and spoke. My first rotations at UCSF Med School were at the San Francisco General in pediatrics, obstetrics, and the Spanish-speaking psychiatry, inpatient psychiatry service. So my Spanish used to be pretty good, but I have not used it very much working clinically at the San Francisco VA, and it is rusty. So we use professional interpreters for all meetings. And as you may know, New York Presbyterian is located in the my upper west side. My New York geography is not great. Near, I think it's called Spanish Harlem. And so there are a number of patients, and the Latin X community in New York was just devastated by COVID. So many patients were Spanish speaking. So many family members were Spanish speaking. We used professional translators. My experience was mostly positive, with one exception. In one instance, I said to a family member that her mother's kidneys had stopped working and would not start working again. And the translator said that her mother's liver had stopped working and would not start working again. And fortunately, I recall enough Spanish to catch that error and correct it. But it reminded me, it made me worried, frankly, that there were other errors I wasn't catching, and reminded me of the importance of checking for understanding, particularly over the phone, because there are so many barriers to communication when you're talking over the phone or doing video consults. Checking for understanding is critical. So using language like, I want to make sure I've done a good job explaining this. Could you explain to me what your understanding is of your mother's situation? And the third take-home point to me was that I was doing inpatient telemedicine consults, right, with hospitalized patients who are in the ICU for the most part, emergency department, ICU, and some on the wards. But that's the exception, right, not the rule. Right. Most of you are here today to talk about outpatient telemedicine, and that's what we'll spend the majority of time talking about today. And I think there's something of note here. New York Presbyterian gave us what they described as their quote-unquote hardest consults, leaving their on-site physicians free to handle the more relatively straightforward symptom management issues, transfers palliative care unit, and straightforward goals of care discussions. And yet, despite doing these challenging consults from across the country in the inpatient setting, where you'd normally rely to a tremendous extent on being present with the family in the moment, reading their body language and responding to emotion, not just with words, but with empathic body language that can only be expressed in person. Despite those challenges, we felt like we were delivering outstanding care. So I was a skeptic of telemedicine before this experience, okay? But now I'm a fan. If we can do telemedicine in such extraordinary circumstances, then there has to be tremendous potential to care for patients when the stakes are not as high after COVID-19. So those are my remarks, and I'm going to flip over now to see if there are any questions about my talk. I see there's one. All right. Thank you for posting questions in the Q&A. The first question is, in assisting New York City, did you pursue formal approval for practicing medicine across state lines? We did. They set up a remarkably efficient and fast credentialing process. So we got credentialed, we got access, remote access to their electronic medical record, which relies on Epic, within a matter of days. I mean, this was incredible effort by their administrators. And I have to say, their electronic medical record is terrific and allowed us to feel like we were an integral part of the team. We'd be chatting back and forth with the doctors in the ICU, the residents, the whole team, and they'd be chatting back with us. within that electronic record. And we could see, daily what the clinical update is for each of the patients. So now I'd like to introduce the rest of the speakers. Our first speaker is Ashwin Kotwal, who is a physician, assistant professor of medicine, the Division of Geriatrics at UCSF. Ashwin received his BA in anthropology at Northwestern and his master's in biostatistics and MD from the University of Chicago. He completed his internal medicine residency, like me, at Harvard's Brigham and Women's Hospital, and then became the first to complete UCSF's 2-year integrated clinical fellowship in geriatrics and palliative care. And Ashwin is the director of telehealth outpatient palliative care at the San Francisco VA. Next, I'd like to introduce Courtney Lyles. One moment. Courtney is associate professor in the UCSF Division of General Internal Medicine at Zuckerberg San Francisco General Hospital and the UCSF Department of Epidemiology and Biostatistics. Her research specifically focuses on harnessing health information technology to improve patient-provider communication for chronic disease self-management to ultimately reduce disparities. She's currently a PI of 2 R01s. Those are the high-level big research grants from the NIH, working to engage diverse patients in using technology, and helps to lead research and operational the research and operational rollout of telehealth at San Francisco General during the pandemic with diverse populations. And I'd like to introduce Danny Keller. Danny is assistant clinical professor for the UCSF San Francisco State University Doctorate of Physical Therapy program, orthopedic specialist at the UCSF Faculty Practice Physical Therapy Clinic, working with orthopedic, sports, and amputee populations, and a member of the UCSF Interprofessional Specialized Amputee Clinic. And he's a physical therapist for Cal Berkeley Sports Medicine. Great. And now I'd like to see if there are any more questions specifically. Okay, I'm looking at the time, seeing how we're doing. We're doing well. I'd like to open up. Actually, maybe we'll launch in with our first presentation here. I'm going to turn it over to Dr. Ashwin Kotwal, and then we'll have a question and answer session, a brief question and answer session after his presentation before turning on to the next panelist. And then after each panelist, we'll have a brief question and answer. And then at the very end, we'll have a more extensive question and answer session. And we'll try to get to as many of your questions as possible. So Dr. Ashwin Kotwal, please take it away.
Hi, everyone. Thank you, Alex, for the kind introduction and terrific start to this conversation. I'm going to share my screen. Great. Great. So I'm really excited to discuss telehealth for older adults during the COVID-19 pandemic. And my brief discussion will primarily be discussing the practical considerations during a typical ambulatory care visit. So some background. Prior to the COVID-19 pandemic, many older adults were unaware of telehealth options. But when they were asked about their interest, as shown on the right-hand panel in a University of Michigan poll, over half of older adults reported preferences for telehealth and select visits. And this is consistent with recent studies that are emerging about the effectiveness of telehealth. So a recent systematic review of telehealth among older adults published in the Journal of the American Geriatric Society in 2019 identified 17 randomized control trials indicating that telemedicine was feasible and acceptable in ambulatory visits. And this article provided preliminary evidence of the efficacy of diverse telemedicine practices. I think this set the stage for more evidence to emerge showing the efficacy of telemedicine. But fast forward to now, the majority of visits are conducted via telehealth because it can reduce exposure to others during the pandemic. And this has helped to address some of the traditional barriers to in-person care, especially among older adults. These might include geographic limitations, so distance that people need to travel to the clinic, difficulty finding transportation, and functional disabilities that are common as people grow older that may make clinic visits challenging. And it's often preferred, especially for routine visits or when people have established relationships with their clinicians. We can provide nice routine follow-up visits and bring interprofessional teams to patients in many different living situations, including assisted living facilities. So thinking about taking a history during telehealth, I think is slightly different compared to in-person visits. So it requires a lot of reliance on verbal communication because nonverbal cues are limited. Some important tips that I use for taking a good history include preparation. So you want to have high-speed internet, make sure that caregivers or other individuals are available to troubleshoot, that you have technology support available in case you need to get them on the phone, and that patients can use relevant applications or links. I found that when there are multiple steps that are involved to get people onto video, they have to have email access to see a link, they have to download an application, they have to allow access to their mic and camera, that the more steps that are involved, the more likelihood that people may not actually have a successful visit. So having a simpler processes are always better. And showing that your listening is key here. So Alex brought this up when thinking about telehealth inpatient visits, but I'll often use reflection statements or name nonverbal cues or emotions to show that I'm listening. For example, you might state, I can see that this topic is making you nervous. How can I help support you? There are also advantages to telehealth in terms of history taking. This includes medication reconciliation, where you can actually visualize bottles, pills, or organizational schemes. You can view the living environment. You can ask people to actually walk you around their apartment or show you their shower setup and what types of assistive devices they actually have. And you can access caregivers who may not be otherwise able to tend or travel to clinic. Common barriers often arise, and I've showing a few of the common barriers and some mitigation strategies that we might use to address them. Hearing impairment is a very common issue that comes up, especially when people are relying on speakers from their phone or the audio from their computer. So we'll often ask people to use headphones so that to improve their audio quality. Closed captioning is often available, including through Zoom. And then similar principles that you use in in-person visits also apply to telemedicine. So speaking slowly, starting sentences with a person's name to help orient them, and avoiding yelling or exaggerating one's voice. I often fall prey to doing this, so I often have to check myself, making sure that I'm speaking in a way that's easily understandable. For vision impairment, we try to use adaptive devices or programs. Sometimes magnifying software can be helpful. Or if I'm going through a document and I share my screen, I'll often zoom in on particular important text with a plain background to make it easier for people to follow along with what I'm discussing. Cognitive impairment can often be challenging, create barriers to accessing these types of technologies or following along in a long visit staring at your screen. So having caregiver assistance or simplified video or device programs can really help here. And then finally, connectivity and speed. This is really critical, especially in rural locations or areas with poor internet access. If I'm finding that my internet speed is, the audio is choppy, I'll switch over to a landline for audio connection. And I'll also just think about converting to telephone if needed, especially if I'm trying to relay really important information and things are breaking up. You don't want to compromise the integrity of those important conversations. Thinking about the physical exam. So this can understandably make people hesitant, clinicians and patients alike. So in the University of Michigan poll, about 2/3 of older adults were concerned about the quality of the virtual physical exam. The key, I think, is to focus on exam maneuvers that are relevant to the clinical scenario. And if certain exam elements cannot be reasonably completed, which are critical to your clinical judgment, then think about pivoting to an in-person exam and making that work. The physical exam for me relies on inspection, observation, and patient performance of key elements. So it's really important to think about limitations here. Is the camera resolution reasonable? Do you have the appropriate lighting? If the patient is on their own, can they actually manipulate the camera in order to adjust to their own position? Or is the camera in a fixed position on their computer? Some of the strategies I use include having patients use home equipment to obtain vital signs, really coaching people on how to perform elements of the exam. So for example, demonstrating active range of motion, or showing how to palpate a painful area or joint. So lots of coaching can be done, but a surprising number of physical exam maneuvers can actually be achieved at reasonable quality with appropriate coaching, time, and patience. For geriatric clinical exams, we really focus on key elements. So here are the geriatric 4Ms, which were first developed by 3 geriatricians. So Dr. Tonetti of Yale and Drs. Hwang and Molnar of the University of Ottawa. And I'll just go through these really briefly, but these can be done quite effectively through telemedicine. So the first is assessing mind. So helping to manage dementia, treating and preventing delirium, evaluating and treating depression or other mood disorders. So we often administer cognitive assessments over video systems, including the mini-cog, which is a delayed recall and clock draw. So I'll have people draw their clock on a piece of paper and show it to me on the screen. You can also verbally conduct depressive symptom questionnaires. For mobility, here's one picture on the right-hand side, which shows a number of safety hazards in a patient's home. So really assessing for safety, function. People are often sitting in a chair when they're having their visit. So doing a chair stand test that only takes 30 seconds can be a really nice way to assess fall risk and integrate that into clinical plans. Medications. So I mentioned before that being able to actually visualize pills and bottles can be really helpful in thinking through medication management. Are they having trouble with certain medications? How are they organizing these? How can we appropriately deprescribe and assess polypharmacy? So telemedicine has been a really effective way because patients, we're not relying on them remembering to bring pill bottles to clinic. And then lastly, what matters most. So this is really getting at goals of care and planning for the future, often through advanced directives. Prior to the pandemic, there was a lot of concern about whether we would be able to have effective serious illness communication through video because of concerns of building trust and rapport. Are there certain topics that are inappropriate to discuss if you're not there sitting with people? We found that actually it's possible to have really effective communication. And this is a time that's more important than ever to start having these types of conversations. Some of the resources that I've used to discuss advanced directives include the Prepare for Your Care website, which is developed here at UCSF, which is an online advanced care planning tool with advanced directives, scripts, and videos. I'll often share my screen and walk people through these websites and follow it up by sending physical copies of advanced directives. There's also important considerations to take into account when you're discussing medical decisions around serious illness. So myself and colleague, Dr. Lynn Flint, recently published some considerations to take into account with having these types of conversations, including careful preparation, building rapport and trust, communication frameworks or strategies to organize your conversations, and most importantly, responding to emotion to really show that you're there, you're listening, and you're able to support people through challenging times. Lastly, just thinking about wrapping up, I always allow time at the end of my clinical visits for questions and feedback, asking people what can be done better for the next visit, or if this is an appropriate way to continue our clinical relationship. I'll follow up by mailing or providing secure messages surrounding patient education information, and really using your clinical judgment about whether this telemedicine visit was adequate or whether an in-person visit is needed. Fortunately, at the VA, I haven't had to deal with too many billing concerns, but there are some great resources online that can go over some ways to think about billing and some of the relaxed regulations during the pandemic and how those might shift moving forward. So in conclusion, I believe telehealth will continue to be valuable and endure post-pandemic, but it requires careful preparation and modified clinical approaches. But you really have to use your judgment on whether it's appropriate for individual participants or certain clinical scenarios. And really, this is a ripe time for us to learn and improve this method of care delivery. So thank you.
Terrific. Thank you so much, Ashwin. That was a wonderful presentation. I want to ask some questions that were that have come through. One is, after the screen goes blank, is the video session as forgettable as a late night show? So how do you know that you know, the communication you've had with this person is effective? And how do you know that they're following through? How do you follow up on new orders? And
That's a great question.
Role for nursing, and for, you mentioned the interdisciplinary team, and we have a number of nurses interested in your thoughts about nurses' role in the interdisciplinary team in these visits.
Yeah, those are great questions. So thinking about the first question, you know, how do you know that what you're communicating is effective? I think it depends on the scenario. You know, if you have an established relationship with patients, you're able to build trust over time and follow up with people. I think there's a lot of advantages to telehealth. You're able to have more closer interval follow-up after clinical visits to really check in and see how things are going without having to have the patient go back and forth between home and your office. And I think just utilizing some of the core principles of effective communication, reflection, checking for understanding, asking for permission to move on between topics can really make sure that people are on the same page and people aren't getting distracted by really long you know, periods of staring at their screen. I think really similar to actually, Alex, what you brought up with inpatient telehealth visits. Now, thinking about the role of nursing in telehealth, I think it's such a critical role to think about nursing here. Interprofessional teams are important, and I think an advantage of telehealth is you can bring in interprofessional teams to have joint visits. So, for example, if you're having, you know, if a nurse is in a different location, you can actually have them join. I've had joint visits with nurses who are visiting the patient at home so they can show me wounds and their setup and their medications. And so having those voices in the clinical visit can really, really improve the quality of care.
Wow, that's terrific. So we're going to move on in the interest of time, but we'll have more questions for Ashwin later in this show. I'll call it a show. We're going to ask Courtney Lyles to go next. Courtney, welcome to the show. You're up.
Thanks so much, Alex. Let me share my screen. Good afternoon, everyone. I'm based at San Francisco General Hospital, like Alex mentioned in the brief introduction, and so I'm going to be speaking specifically about telehealth related to diverse patients and sort of the digital divide, that and my perspective on how that's going. So I think to jump right into it, I think the pandemic has really shone a light on the digital divide in the United States. And maybe some of you were really aware of this pre-pandemic, but especially with conversations about children not being able to access remote learning via Zoom and other modalities, I think more and more people are discussing this in addition to telehealth, although I think we could be talking about it a little bit more. The three major groups that these stats show that are really having problems connecting are lower income Americans, older adults, and those who live in rural areas. And so these are some data from the national data from the Pew Research Center, and also some other data sources of really just about who owns smartphones and also who has broadband at home, so high-speed data access, which matters especially for video visits, as we all know. The other third component of here is digital skills, and there's not a lot of great national data on digital skills that exist. So this is data just from San Francisco, but I think it's pretty relevant and applies to many cities in the United States, and maybe even San Francisco would be seen as a tech-connected kind of city. So you might expect even better data in San Francisco. So we were very fortunate in San Francisco to have something called the Digital Equity Initiative that sits in our mayor's office of housing and community development. And they conducted a survey a couple of years ago trying to tease apart these exact issues. So use of home internet, and then also the skills, the self-reported skills to be able to use that internet. And the self-reported skills that are defined here as basic digital literacy are being able to send an email, being able to conduct an online search, things of that domain. So overall, San Francisco is very connected, but the bottom line of the slide is when you tease apart these purple bars from the dark blue bars, the digital literacy gaps actually seem to emerge, especially for some of the groups that we see more often at San Francisco General, such as some racial ethnic minority groups, limited English proficient individuals, older adults, and the lowest income San Franciscans. So when you think about the data in this way, there's definitely work to be done both on home internet as well as digital skills. And then lastly, I thought I would show some pre-COVID data on telehealth. Again, not great national statistics, but this is from a digital health incubator called Rock Health that did conduct a nationally representative survey a few years ago. So this is 2017 data. What's interesting about it is they broke out and oversampled groups from some of the categories that are, I would say, of interest to me in terms of thinking about the digital divide. So both what they called vulnerable individuals, so low income or Medicaid populations, and also chronically ill seniors, from healthier groups, younger groups, and overall aging adults that they called the worried well, and then aging adults. And so a lot of information here. I would say the bottom line is that pretty big differences in who had ever tried telemedicine, live synchronous telemedicine using video prior to the pandemic, probably reflecting some of what I showed a second ago in terms of some digital divide barriers. I think what's also interesting though about this figure is actually the fourth line down, which is that who had searched for health information online. And you see here, there are no differences in that line about who is thinking about using some digital tools for health. And I would say we find that over and over again in our research, whenever we talk about patient portals or other features, the interest is very high. And so I don't think that some of these differences in telemedicine are interest related only. I wanted to also touch on the idea of evidence. There are some systematic reviews that Ashwin greatly referred to, especially for older adults. There's others for diabetes care and things like that, that show some positive telemedicine evidence, but I would say we've never done it at scale. And I think we can all state that pretty confidently right now. The evidence that existed pre-COVID was randomized trials, or in a more limited fashion, or the largest broad scale implementation would be at something like Kaiser Permanente, who's offered video visits for a while. But I would say some of the best evidence, at least for disparities and thinking about disparities in telemedicine, really come from parallels maybe for how patients are using patient portals. So when we offer things, digital tools that are integrated into care, the first thing that we've offered is online patient portal access. And there's lots of research about disparities and differences in who takes up patient portal use and how they engage with that over time. And so what I wanted to underscore here is I think there's some lessons learned about how we might move forward and how telemedicine might function post-pandemic, which is, again, just to underscore high interest in patient portal use and patient portal functionality that I think probably translate very well to telemedicine, convenience of care, ease of doing tasks, not taking multiple transportation modes to get into visits or taking time off work. I think those are clear things that all patient groups state. But that the barriers persist, really, a lot of research boiled down maybe into a couple of bullets here of why patients don't use portals that I think have some corollaries for telemedicine. So the first two are about preferences for in-person care and lack of perceived need to be able to use digital modalities. And I think here, what I would say about telemedicine is really, we have a unique moment right now during the pandemic. And I think Alex actually said this very nicely in your preamble, that people are maybe trying something that they weren't perceiving they had a need for before, or weren't sure about, or were skeptical about. And so some of the need and preferences might be actually a little different right now because of the safety of coming in person for obvious reasons into care. And so we need to be thinking about that and making sure that people's experiences, we can harness that and try out some things, because oftentimes the first time people try things, or the first few times they try things, generates their opinions about the technology moving forward. And then related to that, people really have preferences, and we have to honor their preferences for how they want to engage in care. And the key thing here, I would say, would be about the interpersonal elements and the idea that telemedicine and other digital modalities are not a substitute for care in perpetuity, but are used in conjunction with other types of modalities to make sure the highest quality of care can be delivered, and communicating that to patients about how to extend their relationships rather than substitution. That comes up as a concern for patients over and over again. And then the last two things are specific for groups that have some barriers, such as technical support. I really can't say that strongly enough. There's lots of evidence about patients who get locked out with passwords, especially for offering telemedicine through the patient portal in an integrated fashion. Making sure that there's robust how-tos, fact sheets, and support to be able to support them in trying it, especially the first time. And then, of course, speaking about the communication barriers, especially language that Alex also mentioned in his intro talk, about how to get video and phone interpreters online in a smooth way to make sure we're not introducing new communication barriers. So what have we been trying to do, or how are we thinking about this at San Francisco General and other safety net focused clinics? I would say we've thought a lot about how to screen or how to identify patients who might have digital barriers, and what might that be, knowing that we have to keep screening questions to as brief as they possibly can be. But how can we take in data about patients' device ownership and their home or data plan access, and in addition to their interest in doing telemedicine, and also keep a track in the EHR about who is accessing different modalities of care, to make sure that we actually have good data about emerging disparities by key factors that might prevent people who are interested from actually being able to complete a telemedicine telemedicine encounter, and particularly a video encounter. I wanted to touch on lots of community resources and partnerships in this space. There are actually many that I don't have time to mention all of them, but I'll highlight one here that there are many, many resources for individuals who are not connected at home or who do not have devices available to them to actually participate in, especially the video visit portion of telehealth, to refer them to resources. And this one is from the National Digital Inclusion Alliance. And I have another slide with a link on it as well, that keeps actually all of the available programs and also the new programs that are available during the pandemic to even lower costs or remove even additional barriers to broadband and devices at home. So I'll try to keep it brief. I'll take plenty of questions if you have any questions for me, but I agree with the other panelists that telehealth is likely here to stay, especially for the portion of healthcare encounters for which it makes sense to do things remotely and to avoid, frankly, the inconvenience of coming in which some things can be delivered effectively via telehealth modalities. Not all, but some of visits are likely to stay this way, especially as more patients and providers try it out and figure out what's working. I would say, I think to do it equitably, there are a lot of recommendations that I have to really think about how to engage patients and providers and systems in ways that might make sure that all patients who are interested are able to do this. At the patient level, I really can't emphasize enough the idea of communicating both from the leadership perspective and from the provider perspective about how telehealth and digital care can support in-person relationships and how to maintain relationships over time, especially for longitudinal primary care and other kinds of visit types, and really to understand where patients are starting from and what their perceptions are, so you can be offering them their preferred type of care and meeting them where they are. At the provider and system level, I think if we can figure out a seamless or a short way to do this, I really think we should probably know more about people's devices and high-speed internet and skills to make sure that we can refer them to the right resource. So if they need a device, making sure they can be connected with places like the National Digital Inclusion Alliance for devices. If they need skills, they probably need other people to be located with both community organizations and even public libraries who offer a lot of digital literacy support and training, but also then the specific support that they need to use the platforms that we roll out, right? So we ourselves in our healthcare system know what the requirements are for making a patient portal account and how that relates to telemedicine. So we need to be able to support the skills for that, in addition to basic skills or referrals, at least for basic skills out into the community. Robust technical support from the system. And then I'm aware that some of these actually create completely new workflows. And so obviously we really want to support clinicians and team members to address burnout, to make sure that we're scheduling visits in the right form and really supporting team-based care, making sure we're actually improving on those components of this to really support our whole system in being able to do this. So I'll end here with some other links that I'm happy to also put in the chat if anyone's interested, but we've developed a few more example workflows, other resources, how to Zoom videos in 6 languages that are up and available on the Center for Vulnerable Populations website. This is the National Digital Inclusion Alliance link for free and low-cost internet plans. And then there are 2 more playbook resources that I think are pretty useful. The AMA Digital Health Implementation Playbook, and then San Francisco has a digital equity playbook that's really about how do you assess needs and connect people to the right resources in terms of the digital divide. So yeah, I'll stop there.
Terrific. Thank you so much, Courtney. We have a number of questions coming through in the Q&A, and I encourage those of you who are following this live to submit any questions you have to any of our panelists in the Q&A. So there are a whole collection of questions, Courtney, about this concern that the rising tide of telemedicine may not lift all boats equally, and that underserved populations will be left behind. And you addressed many of these issues in your talk. Could I just get you to highlight for our audience what are the positive aspects and the negative aspects of telehealth in providing care to the underserved?
Yeah, I think the positive elements are pretty similar to all populations, and probably accessing telehealth are really about the ease of accessing, the convenience, and then the getting information at the time and the place that the information is needed. And so obviously, especially for lower income patients, probably the barriers for transportation and time off work and childcare potentially could be greater. So there's lots of opportunity to use technology to meet them where they are and to deliver high quality care. I would say the barriers in my domain are several fold, but have a fundamental component, which is really about the devices and the access at home, the broadband at home, and the skills that I think we just need to probably be thinking a little bit more broadly about moving forward. And then there's the more specific interpersonal and trust building components that again are relevant for all patients regardless of where they receive care, making sure that patients feel supported using it and making sure that they feel like they are getting the types of communication that they need. So I think at this moment in time, because more people are trying it, I hope that we're both working on high quality care, and also maybe we could be raising our voice about the need for better broadband and the need for better devices, because we need that for education, but we also need that for healthcare in order to be able to do this at scale effectively.
Terrific. And we have a question about whose responsibility is this? And is it the health system's responsibility? Is it, we're in San Francisco, the city of San Francisco's responsibility to increase broadband? Whose responsibility is it to get patients, the technology to improve digital health literacy so that we are, not providing this service only to the most privileged of our patients?
Yeah, and I think we're doing it in a little bit of a patchwork way now. So, and then maybe that's the way we do a lot of things. I think the way I see it as the healthcare system owns the responsibility probably for at least the simple resources and tools and technical support to use the platforms that they're offering. So we can definitely do a better job on the healthcare system side to make sure that those are available for all of our patients in the languages that they speak at a low literacy level, things like that. I would say the way I think about broadband and devices is probably how we would think about referrals for other social determinants of health. How can we refer out into the community, know what patients need, and then refer out and support the community-based organizations and others in their work, knowing it's a fundamental part of how people live their life, and how can we connect people to potentially broadband the same way we might refer for food or for housing. Like, how can we think about that as a broad thing that we need to know about, because it interferes with how they're able to interact with the information that we are providing them with. So hopefully thinking of like that in the future.
Yeah, it's going to take movement on all of these different levels in order to overcome these challenges. And one source of support. So Courtney, you work at the Zuckerberg San Francisco General Hospital. One question from our alumni audience is, should we be pushing our Silicon Valley neighbors to do more? Are you aware of any interest in improving access? I mean, this should be in their sweet spot for so many of them. This is why Zuckerberg donated to San Francisco General, because it is, an underserved population. This is a way they can help using technology that they've helped to create.
I think so. I've talked to many. I haven't had any specific person bite on this issue, but I do think it blends the tech focus, Silicon Valley focus of the Bay Area with our healthcare and our fundamental healthcare needs. I will say, though, we did just get, it's an anonymous donation. I'm not sure who the donor was. We did just get $2 million donation to San Francisco General through the Hospital Foundation to actually work on digital literacy skills for our patients for telehealth that I'm helping to lead up. So we do have one gift, and really it's about how can we think about the sort of what I described, the referral process or the one-on-one training needs for our patients that just started. It was just announced by our CEO, Susan Ehrlich. But I think we'll know more in the future, and at least we're going to work on it in a moderate size in the next few years and can report back.
Terrific. And this is an opportunity. Any of you out in the audience or watching this on video format after the fact, if you have connections in Silicon Valley, this is an opportunity for them to show use both their technological expertise, as Courtney said, and show that they're trying to make a difference in an important area that they care about by increasing access, broadband, digital literacy, giving people the devices they need in order to access these services. We're going to move on now. In the interest of time, we'll have more questions for Courtney and for Ashwin later in the program. But for now, we're going to move on to Danny Keller. Danny, welcome to the show.
Thanks for having me. All right, I'm following up some good presentations, so I'm going to try to make it interesting here. So I'm going to talk a little bit more about how physical therapy has adapted to the telehealth world, as most people think of physical therapy as a non-telehealth option. Again, how does this even work? My problems need hands-on care. PT is not something that works well with telehealth. You must be struggling to help people with telehealth. Common things that we hear and we've had to address as we've gone through the process. So what we'll talk about today is how we've transitioned in the physical therapy department to telehealth-based treatments in the COVID era. Where were we before and where are we now? We'll talk a little bit about patient satisfaction, which is something we've looked heavily at in the physical therapy department, what we've learned, and what the future looks like. So what did that transition look like? Well, what does the UCSF faculty practice look like? We have 3 outpatient clinics throughout the city. We have one at Mission Bay, one at Mount Zion, and one at Lakeshore. We have 44 board certified clinicians. We have 27 orthopedic specialists, 5 neurological specialists, 2 geriatric specialists, 2 sports specialists, and then we have 8 that are non-specialized. Before COVID, telehealth was not really a big part of our group. It's been available for a few years now. Research that's been done in the field of telehealth physical therapy or telerehab has been positive. It's shown good cost effectiveness, and it's shown good outcomes and equivalent outcomes in total joint replacements. But there hasn't been a lot of telehealth research done outside of the total joint replacement field. When we look back at the same time last year of the beginning of COVID from March 22nd to May 16th of 2019, our total number of visits or total percentage of visits for telehealth were less than 1%. Majority of physical therapy was done in person across all spectrums of specialties. All of the PT visits that were done via telehealth were still performed in the clinic spaces by the physical therapists. So there was no home-based telehealth physical therapy being done. And there was minimal insurance coverage. Medicare did not cover telehealth physical therapy. And so there were only a few private insurances that would allow it over time. And no evaluations were covered as well. Transitioning to the COVID era, starting March 22nd of this year and looking at that same time period till May 16th of this year, we had about 85% of our visits transition to telehealth in that period of time. So a huge shift in how we had to treat and how we had to think about how to get these patients better. All of our clinicians throughout our 3 different locations transitioned to the majority telehealth visits. We had a few that were left over in clinic for post-op or severe acute injuries, but the majority of visits were transitioned to telehealth. Majority of the clinicians that did transition over were working from home as we were trying to keep spacing in the clinic and not have that many people there. And over time, slowly, as we started to see the process building and COVID, the lockdowns growing and shelter in place growing, we started to see more and more of the private insurers beginning to cover telehealth physical therapy. Unfortunately, the last one to come around was the federal government with Medicare. So it took a long time for Medicare to come back, but they did end up retroactively authorizing all of the things from March 1st after about 2 months of doing physical therapy via telehealth. UCSF was luckily allowing us to do it even in that process, assuming that it was going to happen. Once they started to transition, They began to allow evaluation codes and other normal physical therapy codes for things like therapeutic exercise and patient education to be charged. So what does that look like? What was our split between those two comparison dates? If we look back at the same time of March to May of 2019, our total number of visits were just over 9,200. And in that same period in 2020, we had just over 4,500. So about cut in half the number of total visits that we were seeing because of COVID. However, if you look at the charts, what you see is almost a flip in the percentage of telehealth to in-person. The very low, less than 1% of telehealth then transitions to a 16% telehealth evaluation percentage and a 69% telehealth follow-up percentage. So a huge, huge shift for us. So how did we transition this? Early adoption was key. Our clinic was great about saying, this is what's happening. This is what we need to do. Our patients still need to be seen. And so we need to get them in. We had a lot of at-risk patients, and so we needed to get them in. We had some fantastic leadership that involved that and clinician involvement, a lot of small regular meetings every week or every other week to discuss it, building task force to develop solutions to specific problems that were coming up, involving our administrative team in our clinician teams, and really trying to work together for scheduling and balancing how we were going to get a hold of patients and communication and dealing with barriers to technology. Looking at real-time data analysis, we had some amazing data miners that were helping us out, looking at the data real time. And then also, most importantly, involving the patients, which I'll get into with our patient satisfaction survey, but really having a conversation of how do we involve our patients in this process? So how does it work? Well, this is a quote that I like to think about when I think about telehealth PT, which is people start to heal the moment they feel heard. One benefit to telehealth physical therapy is that it doesn't take out the subjective component. And so it's still going to allow us to have that conversation with the patient, answer questions. We can get a pretty good idea about red flags. Objectively, there's a lot of things that we can measure. We can still look at range of motion. There's good validity in terms of measuring range of motion on screen. We can look at functional strength measures instead of manual muscle tests, which has been shown to be fairly close. Manual muscle testing hasn't been completely valid, even in the clinic. And then we can modify special tests as we go, which is something we've worked on, trying to figure out how do we work together as clinicians to find out how we can test these patients for specific diagnoses. Creating a home program, lots of different options with therapeutic exercise, patient education, self-mobilization techniques. And then looking at the planning, do we continue in telehealth? Do we transition them to in-person? As we've increased our in-person visits, we've been allowed to kind of transition people that we feel like need to be in the clinic over time. And then looking at that follow-up, a lot of question and answer, exercise demos, either videos or pictures, and providing a lot of patient education, which is the most important key. When we look at that objective measurability, there's been multiple studies that have been done to say how accurate is it to use something like a goniometer on the screen. And even though there's limited evidence on it, all of the studies show a high level of accuracy compared to in-clinic measurement. So it is very, very, very accurate. Obviously, the bigger the screen you have, the better. We've realized that. But the use of goniometric measurement for objective range of motion measures has been extremely validated. Some examples of exercise programs, educations, because I'm sure people are curious what we do on a regular basis. It's been kind of fun. It's been exciting. Self-mobilization techniques. We use suction cups a lot. We call it negative pressure or myofascial decompression in the clinic. Having a patient pick up a kit for $15 and walking them through it and helping them get that some form of hands-on therapy has been extremely successful. I've done a lot of equipment setup, whether it be ergonomic workstations, Pelotons, or like the new popular thing. I've probably fit about 100 people to a Peloton. And so a lot of different things that we can see, as some of the other speakers talked about, we can really see home environments a lot better, which is kind of a new thing for us. We've always talked about it, but never been able to see it. This is a fun example I wanted to show you all of the process that we went through with one patient who had Parkinson's with also a lot of low back pain and hip issues. And what we ended up doing with him was we decided we were going to do a karaoke version because he was a karaoke singer. He loved to sing and he wasn't able to go out and sing because of COVID. So I'm just going to show you a short clip of this real quick.
In other words, please be true. In other words, I love you.
So one fun thing that we were able to do with him, we ended up setting up a large concert for him over time. And got in about 100 different people to come in and watch him sing and dance. It involved a lot of big movements, which are good for Parkinson's. It involved him projecting his voice, which was pretty awesome. So it was a lot of fun too. So transitioning into patient satisfaction, which is something that we really wanted to monitor. It was really a rare opportunity to take a look at some of this in large scale. So I worked with multiple people in our department, Matthew Miller and Sam Pack, as well as Deb Barnes on the geriatric side. And we really looked at evaluating telehealth satisfaction. How are these people liking what they were getting? What can we do better? What are we doing well? And so we put this together. Press Ganey wasn't really assessing telehealth at the time. We needed feedback. We were doing this in a very rushed way at a very large scale. And so we needed feedback. We needed to know how it was going. We needed to be able to understand the barriers that people were having so we could address those. And then again, it was a real rare opportunity to have this large scale of telehealth PT that we had never had in the past. We put together a telehealth satisfaction survey. It involved 10 questions with a 5-point Likert scale, where 0 was not satisfied at all, 5 was very satisfied. And then we had a 1 yes/no question. Would you do telehealth PT again? And we had 3 open-ended questions that allowed for the improvements, the best part, and general comments. So what did we find with our telehealth survey? We had a total of 4,548 total PT sessions within that time period from March 22nd to May 16th. 85% of those were telehealth. We recorded a 94% satisfaction rate, with 92% of the respondees stating that they would attend another telehealth session again. And so we felt really, really good about what we were finding. And it was able to give our clinicians a lot of feedback that what they were doing was working really well, and the patients were really responding well to it. So looking at what we've learned, there were obviously a lot of barriers when we first started. Technology, as some of the other speakers have talked about, has been a big issue. Not everyone has access to technology. Not everyone has access to reliable technology. And so understanding how to improve that has been obviously a challenge. Looking at available equipment for physical therapists, what did they have at home? What could they get at home? How was their internet at home? Insurance reimbursement has always been a challenge for physical therapy, but was extremely difficult during this era because there was this opinion of physical therapy can't be done via telehealth. It's transitioned over time, but it's going to continue to be an issue. Scheduling and looking at sending outcome measures to patients was a challenge that we had to overcome. Inability to actually be there in person, palpate, and look specifically at the tissues because it doesn't totally replace the hands-on aspect. What were the benefits of it though? What positives have we taken away from it? We've really improved with our listening and our observation skills. Hands-on skills are important, but also listening to the patient and observing is a whole new realm in telehealth, and it's really required us to focus a lot on it and improve with it. We've been able to improve access for a lot of people in rural populations or areas that don't have easy access of getting into the city. Reducing costs, just parking alone at UCSF is expensive, so it's reduced a lot of cost there. People are really happy with it. We've had some really exciting new opportunities like the karaoke that you saw. Reduced commute for clinicians who are working in the office has been great. And then independence promotion is a big one. We really try to promote independence with patients and getting them to understand that PT is not something that they need to do the rest of their life. This is something that they should be able to transition to on their own. And I think the telehealth aspect of not coming into the clinic has improved that. So some of the stuff that was said after some of these sessions were different than what they had started with, right? I'm really glad that we did this today. I already feel better after our discussion. This has really helped me. I was very skeptical, but I can already feel improvement. So what does our future look like? We absolutely believe that there's a future for physical therapy, telehealth. We are looking at a hybrid model where most evaluations will likely be in person with follow-ups via in-person and telehealth. We will have likely full telehealth programs for patients in rural and poor access areas. We're working with the orthopedic surgery group to develop the integrated sports rehab group, which is full telehealth PT to areas that are underserved. And then some PTs may have a full telehealth day where they work from home and they do telehealth at home to reduce commute and improve spacing in the clinic. And then also looking at interprofessional treatments. I work with the interprofessional specialty amputee group, and we've done multiple meetings interprofessionally, which work out really well for the patients. The last thing is what needs to be done. And what that comes down to is continuation of insurance coverage. We need to continue to fight to have insurances cover it, including fair reimbursement. We need to continue allowing across state telehealth to be done, which wasn't allowed before. We need to try to reduce Medicare cuts. They're trying to cut physical therapy reimbursement by 9% this year. So there's big advocacy for that. And then we need to continue to assess the program, really talk to patients and figure out what we can do better and then we can grow on that. So thank you for that. I appreciate your time. I'm happy to take any questions.
Thank you, Danny. That was terrific. I want to ask a few questions that have come across from our audience. The first is, how are you handling intake? Like the medical history. Are you doing that verbally as part of the evaluation, or are you having the patient fill something out in advance?
Yeah, it's a good question. It's something we struggled with in the beginning. It goes along with kind of the paperwork that came along with it. And we trialed multiple different things in the beginning. We were hand mailing packets. We were trying DocuSign options and people weren't getting them. And so it was pretty tough. So a lot of the stuff that we've transitioned to now has involved email, has involved Apex. There's been more integration with the Apex system now, allowing patients to get the paperwork beforehand. Our administrative team has worked extremely hard on the back end to try to make it an effective and efficient pattern. And so we're getting that stuff to the patients ahead of time now versus not having it at all. A lot of us are still doing a verbal consent as well when we're doing the telehealth visit, just as a backup. But getting that stuff out via Apex or via email or via mail has been a challenge, and it's something that we need to continue to try to improve.
Mm-hmm. Terrific. And then one of the audience members notes, other speakers have talked about telehealth considerations to reach underserved and elderly populations and are interested in how you've addressed this issue in your practice.
Yeah, I think it's something that has been interesting for us because these rural populations, these areas that are way outside of UCSF and don't have good access to UCSF, but would like to see UCSF clinicians, it opens up a whole new world for us. Just in my own personal experience working with Dr. Brian Feely in the orthopedic group, we've really been able to take some of his patients that are from these more rural areas and provide them with physical therapy from UCSF, where I can easily interprofessionally discuss a case with Dr. Feely, and they're getting this really good care that they haven't been able to have access to before. And so I think if we can grow this program and we can start to build that process, being able to provide that care for these rural and underserved populations is going to be amazing on the physical therapy side of things.
Great. And one last question. How does PT work with and communicate with the rest of their team and support staff who are not with them remotely doing telehealth? In other words, they're not in your home with you.
By the rest of our team, you mean the rest of the physical therapy team and the admin team?
Yeah, the rest of the team, the support staff, whoever. Yeah.
So we've gone back and forth on different options there. We settled on Microsoft Teams. So we have a group, multiple groups set up through Microsoft Teams. We have chat options. We can call through Microsoft Teams. So that's been extremely successful because we can do it through phone, we can do it on the computer while I'm doing telehealth. I can respond to messages, I can reach out to people. And so that's been fantastic. Obviously, we're all pretty close in the physical therapy department, so we all have each other's phone numbers as well. But just being able to utilize Teams has been probably the biggest thing, because it's allowed us to share files, allowed us to have chats, allowed us to have check-ins, and it's allowed a lot more efficiency with communication.
Great. Terrific. Thank you. I'd like to invite our other panelists, Courtney Lyles and Ashwin Kotwal, to turn on their videos now. And we're going to spend the last 15 minutes talking about questions that have come through both in advance and today. First question for any of you, are there any DEA restrictions on prescribing opioids via telehealth? And Ashwin, you want to try to take that one maybe?
Yeah, sure. Prior to the pandemic, there were regulations on prescribing opioids through telehealth through the Ryan-Haight Act. Some of those regulations were relaxed during the pandemic to allow face-to-face video interaction as a means to prescribe opioids. I think there's still limitations in prescribing opioids if all interaction is over the telephone, so that's still important consideration. And it's also unclear how long those relaxed restrictions will continue during the pandemic. So I think that's an important thing to potentially advocate for moving forward, to make sure that we're having regulations on opioids that make sense and that account for individual patient scenarios.
Right. Terrific. Another question about, do video visits count as a face-to-face encounter for the purposes of certifying a patient for home health services? I'm thinking maybe Danny might be able to take this one.
Yeah, I'm not 100% sure on that. I don't work home health, so it might be a better question for a primary care who's generally prescribing that.
Ashwin or Courtney, any ideas? And we don't necessarily have to have the answers to all of these. In fact, we probably won't.
I'm not exactly sure. I know at the VA we use video visits to help certify for home health needs. But yeah, that's a good thing to look into.
Great. Next question. This is about home monitoring. So we have more hypertension treatment in the home using self-measurement devices. I need a drink. So the question is, can you discuss remote monitoring as a component of telehealth for people with chronic conditions? Courtney?
Yeah, happy to jump in there a little bit. Yeah, I think it's really fundamental to what we want to do, what we all probably want to do in telehealth. And so I guess the way that we've thought about it is the workflow really has to be solid, though. From a research perspective, giving out the device and truly understanding the quality of the data, it's been known for a long time now that home blood pressure monitoring and home glucose monitoring works. I would say what we struggle a little bit with is who on the team is going to be responsible for reading those and how will we proactively look at them. But in our EHR, there's already places to hold those readings. I mean, I think a lot of the pieces are there, and hopefully this can push us into that as a fundamental part of what we do, with an eye towards equity, of course, in devices, as I would say. But I think it's a natural thing that we should be thinking about.
Right. And Ashwin or Danny, do you use home monitoring devices in your clinical practice?
So we don't currently. I know that there's been a lot of studies or attempted studies looking at some of the wearable devices on the physical therapy side and with some of the researchers. I know I have a few coworkers who have discussed it with companies like Mirror, who are doing these home-based exercise and new machines where you can have monitoring there. It hasn't really gone anywhere yet, but I think 5-10 years down the road, I think from an exercise prescription standpoint, from a monitoring standpoint on the physical therapy side, you may start to see some of these things where you're getting this kind of virtual full assessment while you're doing the motion analysis.
It's a really topical, right? I just saw a commercial yesterday for, hey, one day there'll be a watch that can measure your oxygen level. Oh, Apple Watch does that now. That one day there'll be a watch that can measure your EKG. Oh, the Apple Watch does that now. So these monitoring devices increasingly used Ashwin, are you using them at all in your clinical practice?
I have not had to use them in my clinical practice, but I imagine there will be come a time where it's really convenient, especially taking home vitals during a clinical visit. If you already have a collection of those that are monitored over time prior to the visit that you can pull up easily, that can improve the efficiency, really streamline the process. Yeah, it would be great.
Yeah, great in some sense. On the other hand, you don't know what to do with these reams and reams of continuous blood pressure monitoring data, right? Or continuous EKG. Oh boy, that's a lot of data to sift through. And does it mean anything? Because that's not what was used in randomized trials, right? Another question for you, Ashwin. Is there any movement in geriatrics to increase home visit programs by pivoting to do these virtually?
That's a great question. I think, as we talked about a little bit, there are advantages in being able to see the home environment, but there are also situations where you really need to make exceptions to the pandemic restrictions and go visit people and see how things are going, especially for safety considerations. I think I'd be interested in what other panelists have to say about combining some of these different modalities of communication into single visits. I certainly have seen nurses go to the home and then having joint visits with them from my office space. And I imagine that might be helpful, especially when incorporating the interprofessional team.
Yeah, it's a great story. I wanted to flip to talk about an insurance question. What do you think will happen with insurance companies? Are they going to continue to reimburse after COVID? And in fact, one a member of our audience writes that I've heard from my biller that some companies like Aetna will no longer cover such visits after September 30th. Anybody heard anything about this?
So I can talk about from the physical therapy side of things.
Please.
There's obviously it's been a big conversation of this is a temporary thing. This is only during the pandemic emergency. We're not going to maintain this. And then it's transitioned to, there's this deadline of August 1st. Oh, now we're going to push it back to September 30th. Now we're going to push it back. And so I think no one really knows, to be honest. I know that we're advocating really hard for it in physical therapy to maintain it. I know a lot of other health professions are. I think that a lot of insurance companies are going to fight doing it, but I think at the end of the day, there's going to be an overwhelming majority of healthcare professionals that believe that this needs to be at least a part of the future of care. And I think they're going to have a hard time denying it over time because they're going to get a lot of feedback from patients that are having successful experiences with it. So I'm hoping that it will continue, but I think it's just going to keep getting pushed and pushed and pushed until eventually something happens.
Courtney, anything to add?
No, I was going to say something very similar. I think they're probably going to be extending the temporary state for a while, but in terms of the future, like more static state, it's still to be determined about what they're planning on doing.
Mm-hmm. And what are the barriers to it just making it a permanent change? I mean, from any thoughts?
I'm not sure about the high level barriers besides some of the state crossing lines and some of the other things that have already been brought up. From the system side, there was a lot of concerns about the privacy and security of doing this. And so there are a lot of conversations about, and right now those are relaxed, right? So you're able to do telemedicine through lots of modalities, like even FaceTime and other modalities. But in the future state, I would imagine that those will be more restricted and probably heading towards what I alluded to in my talk, which is telemedicine integrated into the electronic health record, so that the secure login into the online patient portal, like MyChart, is a one-time login that then the Zoom client or WebEx or whatever your EHR links to is how you launch the video encounter. And so I think there's definitely a push for that. But I think there's lots of things to work out, right? How are all the patients on the patient portal and lots of other things to get there. But to me, that's the future state, most likely, to keep as much of it integrated, both for billing and for tracking, but also for privacy and security.
Mm-hmm. Danny, I want to come back to you with a question from our audience. How do we effectively implement telehealth for high-risk patients with limited mobility who rely on physical therapy? And also, related question, suggestions for safely examining patients with limited mobility via telehealth. patients who have cerebral palsy, MS, et cetera?
I think it's a really good question. I think it's something that we've talked about a lot. I work on the orthopedic side, but I also work with amputees, which especially early on are a fall risk, post-op fall risk. I have a lot of neurological coworkers who deal with MS, ALS, Parkinson's. The video that I showed was a Parkinson's patient. And really what it comes down to is preparing the space. You've got to really make sure that because you're not there, you're confident that whatever space they're working in is a safe environment. For the patient that I showed in the video, I made sure that he had a chair behind him, his walker in front of him. His sister was in the room. There was a lot of precaution that we took before we had him doing any sort of movements and activities. And so I think it's very safe to do. Most of these people are moving around their house on their own without too much issue. So you can do it, but it's all about preparation and making sure that you have that conversation with the patient that here's what we're going to do. This is what I want you to set up before you do anything. If you need help, let's have your caregiver help you out.
Mm-hmm. It's great. It's a question for Danny or Ashwin or Courtney. One of our audience members asks, and this relates to what you just talked about, Courtney, privacy concerns. Have patients expressed any concerns about HIPAA or data privacy issues in participating in healthcare via Zoom or other video systems?
I think different patients definitely have different concerns about privacy and security. So we've tried to think about it more from the proactive stance of how to communicate what's actually going to happen so that nobody's surprised in this current state, or that you'll be able to see your background, especially for people who have never tried out these platforms before, just to make sure that they understand about having a safe or quiet space to have their visit if they need that, and sort of prep that a little bit more. But I get asked a lot about our patients, lower income patients, being concerned about showing their backgrounds or where they live in terms of visits. And that we've interviewed a number of patients, 25 in English, Spanish, and Cantonese at the General. And most of them feel pretty confident as long as they have autonomy over how the visit's going to happen about that piece of it. It hasn't been the primary thing that they seem to be concerned about.
Mm-hmm. Ashwin? Have you had any patients express concerns about privacy? You work with predominantly older population, maybe less familiar with technology. I mean, my dad refused to do email because he thought that other people could intercept it at any time, which may be true.
That may not be unfounded. I have not personally come across as many security or privacy concerns amongst patients. I think in many ways, it's been on my end that I've had to ensure that I'm maintaining a quiet atmosphere that's relatively peaceful, free of distractions, because we're often calling into their homes. They have an ability to control their environment, or at least they're used to it. So I think it's important to remember it goes both ways. That we both have to be thinking about how to best be respectful.
Great. All right, we have 1 minute left. I just want to give our panelists time for one pithy thought. We're going to start with Danny, and then go to Courtney, and then Ashwin. Danny, one final thought about telemedicine. Will it endure after COVID?
Yeah, I mean, I think, first of all, thanks for having me. And second of all, I think physical therapy telehealth is extremely important. I do think it will endure. I think that the hybrid system is going to be really important, especially for reaching these rural and underserved populations. I think we really have to advocate, both our patients and us as clinicians, to really make sure that we maintain coverage and that they don't start cutting for physical therapy, because that's going to be really important. So reaching out to our, local and federal governments and saying, this is important to me, talking to your patients and saying, if you really want this, reach out to your senators and say, this is important to me. This is important to my health. This is allowing me access to something that I haven't had before. And I think if we can do that, it's going to be extremely successful in the future.
Thank you, Danny. Courtney.
Yeah, thank you also. And I would say many patients are interested in telehealth. And I think with a few steps and proactive moves, we can try to do it equitably. Now is the time to maybe try out something differently than we've been doing in the past.
Mm-hmm. Great. Ashwin.
Yeah, thank you for allowing me to be here. I'll Second, Danny and Courtney's thoughts. This is a great time for advocacy, and the time is ripe really to make a difference here and support vulnerable populations.
Terrific. And I want to say thank you to all of our panelists. This was a wonderful presentation, and I want to say thank you to all of the alumni who are on this Zoom call or watching it later for your questions, interest, and participation. Thanks, folks. Goodbye.